our mission to focus on brands and help amplify brands and voices that are driving health equity and inclusivity. And so the Mitra Collective is really a community of people and a network that is really here to advocate, amplify, and prioritize health equity and inclusivity businesses, initiatives, products, services. And so this space is meant to facilitate that and also educate others beyond specific product development or service development, and really help align on a shared understanding of various barriers and unmet needs that get in the way of creating an equitable healthcare landscape. So that being said, I will allow all of our panelists to introduce themselves. The aim of this week is obviously in honor of Pride, and so everyone we have here has a very specific and broad perspective. So we have many different disciplines and areas of expertise represented. We're super excited to bring together today. So I'll just name off some folks from my screen left to right. So Greg, you're first if you want to introduce yourself to the group.
Good afternoon, everyone. My name is Greg Ryder. My pronouns are he and his. My title is Director of Corporate Compliance for Emblem Health, which is a regional health plan based in New York City. And I also am the leader and founder of our LGBTQ Employee Resource Group, as well as a founding member of our DEI Council. And so I see my role as helping to spread the message about health equity, about the needs of LGBTQ health patients and members, share information, share resources. And so I'm thrilled to be here today. Some of my areas of expertise outside of compliance would be employee resource groups, sort of mindfulness and showing up, how that impacts who we are, our professional growth, and just being able to be present for all the parts of our lives. So great to be here. Thanks for inviting me.
Thanks, Greg. Lauren?
Sure. Hi, I'm Lauren Gray. Very nice to meet you all. Use pronouns she, her. I'm Senior Vice President of Communications and Brand at the Human Rights Campaign, which is the largest LGBTQ civil rights group in the US. Prior to being at HRC, I worked at Edelman for 5 years, which is a global communications firm. While I was there, I worked with Fortune 500 companies to deal with complex issues related to societal issues, including LGBTQ issues as a thing, and then also did work with our client, UNFPA, which is the UN agency that is dedicated to global sexual and reproductive health care. I've also worked with, I know Dr. Kaiser is joining us from Northern California. I worked for NCLR in California, which is an LGBTQ litigation group. So there worked with them to help combat the first transgender military ban from former President Donald Trump that's now been repealed, et cetera. Actually have a law degree with a focus in human rights, and then have done advocacy as well in my personal life. So worked for 3 years in Philadelphia at the LGBTQ Center there as a crisis counselor on mental health issues.
Lauren. Dr. Kaiser, go ahead.
Thanks, Kate. Excited to be on the panel today. My name is Dr. Daniel Kaiser, he, him. Happy Pride, everyone. I'm a reproductive endocrinologist and infertility physician by training, and care for patients of all types who are looking to start or grow their family, primarily through assisted reproduction and IVF technologies. Really a passion of mine in reproductive medicine, in that I knew when I set out in my own training, in order to become a father the way that I was considering becoming a father, I would need to access this type of technology. And so, care deeply about this community and the process of egg donation and gestational surrogacy. I head up our what's called third-party reproduction program and LGBTQ care at Reproductive Medicine Associates of Northern California. Our main office is in San Francisco and a few offices throughout the Bay Area. And about a third of the patients and couples that I care for a variety of reasons, are seeking care through egg donation, sperm donation, gestational surrogacy, embryo donation. RMA is a part of a large, now international network of fertility practices, of the largest global group of fertility practices in Northern America, South America, now Europe. We have about 4,500 employees, and since its inception in the 1990s, have been deeply invested and rooted in kind of culturally competent care, and trying always to be ahead of the forefront in terms of access to care, kind of advocating for the LGBTQ community. So my husband and I'll just add, my husband and I now have 2 kids through this process, a 4-year-old boy and a 6-month-old little girl. So clinically do this every day, but then also have the kind of personal experience of going through it as a patient. And that, I think, offers a little unique perspective in terms of the different roadblocks, kind of speed bumps along the way.
Okay, sorry. So with that, I don't want to delay any further from getting into our discussion. You touched on it a bit. Our first topic of the day is cultural competency. I think one of the things that we talked about in a bit of our prep discussion is how cultural competency plays out in so many different areas of life, whether it's in the workplace, and many of us are people managers, work for brands, right? Socially, of course, and then point of care. So given we have a variety of different perspectives here, would love to hear from each of you what cultural competency really means, and how you see that, either the lack thereof getting in the way, or ways that you also see it productively advancing a more equitable and inclusive ecosystem. So Lauren, let's start with you and kind of the macro societal view and how impactful that really is.
Great. Thank you, Kate. Well, I just wanted to start by saying that I've been in a number of Pride discussions this month, hosted in different workplaces. And one of the most common questions that I've heard from folks in different workplaces is sort of a fear of not getting it right, or a fear of making a mistake, or what to do in a situation like that, or how that could be perceived. And so I just want to start by saying that this is a safe place where we want to share information and learn and grow together, with the recognition that no one knows everything about every different experience or group. And that I am really thrilled that folks are on wanting to talk more about being culturally competent on LGBTQ issues and learning more together as a thing. When we talk about it in a healthcare context, I think that we're really thinking about it in a sense of trying to make sure that folks are informed about the issues that are impacting the LGBTQ community when we talk about being culturally competent, and that they're taking active steps to try to reduce disparities, which I'm sure Dr. Kaiser and Greg can speak more about. But really looking to further high quality healthcare, provide a very safe environment, provide compassionate care, and ensure that there are equitable services. And I know throughout the conversation, we'll chat more about what that looks like, but I also want to talk a little bit briefly about gender affirming care, which is just another way of saying healthcare for transgender folks, because it's something where we tend to get a lot of questions as well in the workplace, or just generally about it as a topic. So just wanted to start by saying that it is considered medically necessary. It's safe healthcare. It's backed by decades of research, and is supported by every major medical association. In fact, representing over 1.3 million US doctors as a thing. And also wanted to share some new data from Navigator that says that a majority of Americans actually agree that parents, mental health professionals, and doctors are the best folks equipped to make these kinds of decisions about the type of care that folks would need, that a child would need, and are wanting to see actually less of that decision being made in sort of a political or in a government way.
Thanks, Lauren. I think you hit on a lot of different points. And I think there's a lot of stats around the mental health impact and burden as well that comes with the lack of support. All really great points. Is there anything, Greg, that you wanted to add in terms of your thoughts around cultural competency and sort of how that plays out in your line of work?
No, I really like what Lauren said, and I like what she said at the beginning, that we don't have all the answers. And I think it's I sort of get this question, and when some of the presentations and trainings that I do, I think it's an attitude, and it's a commitment to wanting to get it right and not being afraid to make a mistake. And if you do, it's common sense. If you use someone's pronoun by mistake, the wrong one, if you accidentally misgender, if you ask the wrong question, it's a matter of just saying, oh, I'm sorry, that probably was not correct. Please excuse me. How would you like to be referred to? And that's within the corporate setting, it's in with the medical office. So I think cultural competency, it's in a commitment to doing the right thing. I think it's also, and I know that sometimes, we hear that our critics and those folks that are not our allies want to portray us as trying to advocate for special rights and special treatment. We're not, we're all part of a very large inclusive umbrella, but we want to make sure that the specific demographics that we're referring to are getting equal to treatment and care, consideration from their providers. They're getting the same coverage and benefits as folks that don't identify as LGBTQ. So I think that's really what we're about. And cultural competency, when I think about it, is a commitment to doing the right things. It's a commitment to having policies in place that address cultural competency. It's having things as simple as in a medical office or in a hospital, an LGBTQ Bill of Rights. One thing I love about one of the hospital systems here in New York, where I have my care, is with the Mount Sinai Health System. In all their offices, they have on the wall next to the notice of privacy practice, everything else, there's a placard that says LGBTQ Bill of Rights. So it's some of those things, and it's ensuring that our goal is increased quality of care, better health outcomes for everyone. And so it's ensuring that we've got strategy, we've got attitudes, we've got policies, practices, and appropriate tip sheets, training, et cetera. All of that is in place. And it's not just one item, it's ensuring that we're all working together to provide care that makes sense, that's equitable for our LGBTQ patients and members. And so I think that's an exciting place for us all in the way that we shape that and are part of cultural competency in the work that we do each and every day.
Yeah, great points. I think both of you raise and articulate the need to be willing to learn and be vulnerable. And that's a huge part of it. Dr. Kaczor, anything you want to add on the cultural competency front, given you have sort of that frontline point of care experience to add?
Absolutely. On day to day in the clinic, and working as a team in a clinical setting, I would just add that it's always an ongoing process. And similar to Lauren and Greg, it's no one has all of the right answers. I sometimes misspeak and get things wrong. It's acknowledging it, moving on, and just demonstrating that you're a caring clinician and that your team has a patient or couple's best interest in mind. And from the kind of larger practice point of view, it's ongoing clinical continuing medical education for employees, physicians, nursing, medical assistants, the finance team, the front desk who opens the clinic each morning and takes phone calls. It's really 360-degree approach to making sure the whole staff is culturally competent and not making assumptions about why someone's scheduling an appointment or giving them, the wrong intake forms, or assuming that they need a certain intake form when they, need a completely separate one. And, there are organizations that offer, this type of education in a clinical setting. The one that we've used at RMA is called Open Door. But there are a lot of other groups out there that do it, that offer, modules, video and in-person training for staff members about kind of LGBTQ cultural competency. And then Lauren's organization, HRC, offers something called the Healthcare Equality Index, which I imagine Laura will touch on at some point. But the Healthcare Equality Index is a really great benchmarking tool for fertility practices across the country that reviews internal policies and employment policies, also clinical practices within fertility clinics, and gives kind of certain designations to certain fertility clinics that are doing this in essentially a clinically excellent way. So I think that's a great opportunity for patients to have some transparency into the process when they're comparing clinics about where they might feel more or less at home.
Kaiser. So I think we touched on quite a few topics, but I think one place that I always want to make sure we have a shared understanding on, beyond having the cultural competency, or understanding what the particular barriers, gaps, and unmet needs are, and particularly the unique needs of the LGBTQ community. So I think let's dig into kind of a layer deeper, specific to the healthcare landscape and the sort of ancillary support guiding to care, the employer responsibility aspect of care, the policy side of care. Can we dig into maybe first, Lauren? I know there's a bit of an announcement yesterday, so maybe we can start there. I think that's quite topical.
Yes, so a big announcement yesterday from the Supreme Court. I'm not sure how many folks are following right now. This is sort of the season where the Supreme Court is issuing things. There's a blog called SCOTUS blog where they get on at certain days in the court's calendar at 10 a.m. and they share through in real time, everything that's happening, et cetera. So yesterday was a big moment for all of the folks following religiously the blog. And a lot of folks across our community. So the Supreme Court announced that it would grant cert in a case, a Sixth Circuit case actually out of Tennessee that banned gender-affirming care for kids there. This is a huge deal. This will be the first time that the Supreme Court will hear a case on access to healthcare for trans people. And just procedurally, what's happened there is that there was a ban in place. The court issued a preliminary injunction preventing that ban from going into effect, and then overturned that preliminary injunction upon appeal. So in this situation, the court has this incredible opportunity to restore access to care for folks there who have been dealing with a ban for a little bit over a year. And just want to talk about this for a second on a more human level, and just say that everyone deserves access to the medical care they need. And certainly at HRC, we talk a lot about why transgender and non-binary folks should be absolutely no exception to that. And in this case, we are really strongly urging for the court to follow the facts in this case, to listen to the medical community. As I'd mentioned earlier, every single major medical institution supports access to gender-affirming care as a thing, and as well as the American people. So we've actually seen a lot of new data, kind of similar to what I'd mentioned earlier, where people see sort of the overly politicization of access to care and are pushing back on some of that, have said things like, that they see this as a distraction. In a new poll recently, a Navigator poll, 70% said they were concerned that these kinds of issues are being used to divide us in an attempt to gain political power as a thing, et cetera. So really just want to call out how important it is to talk about care as a decision between doctors and families. and the incredible importance of this from a mental health perspective as well, for people to be able to access the care that they need.
A really important topic and great point about it being really between the patient and the doctor, and understanding what's the right care for you as an individual is super important. Thanks for walking us through that. I think given we're talking about, the care aspect of things, I'll jump to Dr. Kaiser and see if you have anything you want to add from the access to care and how making that really individualized, personalized decision for a care plan is so important.
Yeah, access, in my opinion, is really one of the foremost issues for this community seeking fertility care. And historically, so IVF was invented in the late 1970s, 1980s, and really grew in the late 1990s and early 2000s. And a lot of the fertility practices that were established are started in that time frame, where a family is a quote unquote more traditional family, a man, a woman, seeking, who had difficulty conceiving and are accessing medical care to try to get pregnant or to grow their family. And as such, a lot of the traditional insurers that pay for this type of treatment are kind of deeply rooted in that traditional definition of infertility, of trying to conceive for 6 to 12 months between a man and a woman. And as such, they don't recognize a couple needing an egg donor or surrogate or sperm donor as truly infertile. And so the net result of that is a lot of these patients with traditional insurance would be paying out of pocket, even if their benefits would outline that they have IVF. They just can't tap into that aspect of their plan, because historically they haven't been able to be medically defined as infertile. Fortunately, last year, ASRM, the American Society for Reproductive Medicine, which is the kind of national organization for reproductive medicine, redefined infertility and specified it's no longer solely trying for 6 to 12 months between a man and a woman, but it's rather the inability to have a successful ongoing pregnancy based on your medical history, your sex, or some other aspect of your reproductive history. And it also now includes caveats about it's not limited to the use of donor egg or donor sperm or gestational surrogacy. And so our national organizations are baking into the definition of infertility like a more comprehensive, contemporary definition of the couples and individuals that we're treating. And hopeful remains to be seen, but that the payers will catch up. And there's there are ongoing class action lawsuits where LGBTQ patients and couples are suing insurers or even states or cities based on their denial of this type of service. That I think is kind of a longer term scope, and I think will continue to slowly evolve. The more nimble kind of non-traditional payers in our space, companies like Progyny or Carrot or Maven or Kindbody, these groups are really revolutionizing who has access to care, and they're no longer determining who can access fertility treatment based on sexual orientation or partner status. And so whether I'm working with a single male or a lesbian couple or a trans man, with these new kind of fertility benefit solutions, all of these patients have access to kind of the full gamut of reproductive care, which for me as a clinician just makes my job so much more easier in terms of counseling about the options and helping them find what the right option is to start their family. So it's an evolving story as well, but particularly as larger companies are adopting these fertility kind of benefit carve-outs, and frankly, prospective employees are seeking out jobs that offer fertility benefits, or speaking up to their HR department about access to benefits. I think that's a real kind of key component to caring for this group.
Yeah, I mean, you highlight a really good point is, if you're coming out of pocket, that immediately presents a barrier, right? And I think even with the acquisition of April by Progyny emphasizes the fact that employers are recognizing the role and responsibility in making sure there is equal and access to family planning services. So all great points. I think, Greg, one of the things that you had mentioned in our chat was the Affordable Care Act and the finalization of Rule Section 1557. Do you want to elaborate on that a bit and how that kind of plays into all of this?
Yeah, it's just another sort of layer that plays into what Dr. Kaiser and Lauren said. So earlier this year, there was a finalization through the Department of Health and Human Services of what's called Section 1557 of the Affordable Care Act. It actually was rescinding sort of discrimination against LGBTQ individuals that were put in place through the previous administration. And so it's expanding non-discrimination protections. So any organization, insurer, clinical, anyone that would be considered under the rule, under sort of CMS and HIPAA, a covered entity, they need to ensure that there are non-discrimination practices in place for LGBTQ individuals relating, sexual orientation, gender identity. So there has to be access provided for those individuals. And that includes gender affirming care and surgery as referenced. That would also include any pre or post surgical care that's related to that. It's just a win-win, and it goes clearly aligning with the SCOTUS decision. I mean, so you've got sort of two arms of government sort of addressing the same thing. One is for more clinical sort of HHS perspective, the other is from a more legal, but it expands discrimination protections, and which is a good thing. And to my point earlier, this is ensuring that all demographics, so those that might have language barriers, accessibility issues, that's included under this revised final rule. So it's all good news. And again, this is all based on, evidence, scientific driven, medical necessity. Those are all the driving factors for all of these decisions in these cases, not any one individual's particular preference or beliefs or whatever, however this would be characterized.
I think the next thing we wanted to talk about today was the role of stigma and biases and the more broad cultural and societal aspects of things. How do we overcome stigmas? How do we shift perspective? And then how does that translate in point of care, in medical biases, right? So how we sort of act as a brand in communications on a more public stage certainly parlays into these sort of smaller, more individualized settings. And so I think, Lauren, I would love to hear your thoughts, given your background in communications and working with brands. But how do we, on a societal and cultural level, and what is the role that employers and brands play in kind of shifting, the cultural stigmas and addressing some of those biases?
Yeah, that's a great question, Kate. And I think it's hard to talk about some of the stigma and biases without talking a little bit about misinformation and disinformation as a thing, which I know is, such a central concern to so many folks right now in communications and within the news industry, in digital spaces, et cetera, and for many businesses as well. So really thinking through as as a company, the trust that you have with the folks that work for you as a trusted source of information. And we talked about this a little bit a couple days ago, Kate and I, when we'd been talking about this panel, but the US is in a really unique position from a healthcare perspective because we have an employer-provided system of healthcare, which what we've seen in doing some of the consulting that I had done when I was at Edelman at different businesses is it creates just a huge pipeline of questions from workers and employees, et cetera, to their employers for answers, and creates kind of a responsibility for employers to be able to address information and counter misinformation in these instances as a thing. One thing that was really interesting was that we had done some counseling for companies in the aftermath of Roe, and we really saw a number of the overturn of Roe, sorry. We really saw a number of companies who, maybe for the first time, really had to sit down as a team and talk to insurance providers and say, actually, we're not even really sure what benefits we provide. Can we talk about what this looks like? Because we're getting just absolutely flooded with questions from folks about, what these changes and policies will mean for their families, for them, for their access to healthcare. So it's really difficult to divorce, I think, the need for employers to be able to provide healthcare information and make those connections as a thing in their roles leading workplaces. From a communications perspective with regard to bias as well, some interesting tactics that we're seeing now to try to counter misinformation. So this will probably make Kate smile, but as communications professionals, we're often taught not to put things in a negative frame, not to say what something is not, that automatically makes your audience think exactly, what you're trying to say something is not. So a really classic example that is always used is Richard Nixon's "I am not a crook," right? And this is this kind of like historic soundbite where, the impact of that statement was so different than his intent in using it. But we're really seeing for the first time in a long time, kind of this return to trying to use not in a way to counter misinformation, and it's having some success. So, calling out that audiences are about to hear things that are not true, or calling out that they're getting or receiving information that is not true, and then very clearly identifying what that information is. These are some things that I'm hearing from communications colleagues just across the profession as ways that we're kind of more effectively countering some of these misleading messages or misinformation about bias and stigma, et cetera. So definitely something that we are looking at in the lead up to the election, which I know has been such a central focus as well for HRC, and wanted to just give a plug on that to on one point, and that's that, Greg, you mentioned earlier that we as a community often really show up, and wanted to just say that my background is a campaign that we've recently launched at HRC about showing up, and it references the election and some of the work we're doing right now in battleground states in the lead up to the election, but it's also supposed to kind of reference the community historically, that it has really shown up for each other, that we have really shown up to continue to drive change, and that the community itself has been so responsible for driving a lot of advocacy and work in progress as a thing. So Greg was so grateful that you just mentioned that incidentally. Thank you.
Yeah, thank you. And Greg, I'll turn it over to you, but how are you seeing overcoming cultural stigmas and biases and showing up both as an employer, but then as a people leader? If you could speak on that a bit.
Yeah, thank you. And this is all great dialogue. I'm just enjoying what Lauren and Dr. Kaiser are saying. It's just so helpful, and again, just so grateful to be part of this discussion. I think, it's about employee engagement, it's about showing up. I mean, if you look, not that anything happens just sort of like start to finish, but, at some point in any company, there has to be, some LGBT out people that show up, and it's known who they are, and they're not afraid to sort of be those trailblazers, and they may be the people that start your employee resource group, or may just be people that help to start discussions about LGBTQ employees. As Lauren said, well, what benefits are we offering? It's taking the time to look, are we excluding anybody that we may not be meaning to, but we are? And then you need to ensure that you can access and get senior leader support, have them to show up as appropriate, make statements. You can't have your senior leaders making statement about every social issue or things that show up, but work with your communications team to strategically look at where are points in the year that we know we want to address and how can we respond to things that pop up. And then one thing that I had mentioned yesterday in our discussion, those folks that want to sort of help drive these changes, that want to help get the discussion started, they should be folks that are seen as trustworthy, as honest, that I don't want to say that that you have to be liked, but they should be people that generally generate a positive impression throughout the company. You don't want someone that's known as being quick to anger and quick to criticize, sort of coming into your leadership team and saying, I want to talk to you about what we should do about LGBTQ employees. So those are all part of fostering relationships, fostering people that can work with the leadership team. And then they should also be people, or addition to those, you need people that have connections with your community. That's where HRC is so good at. They're both an external resource, but they also help people become better leaders within their organizations, within their communities. They've got all kinds of tools. Dr. Kaiser talked about HRC's Healthcare Equality Index. They also have one called the Corporate Equality Index. And one of the things that PRISM, which is the LGBT group, was so happy to be part of in our early years, one of the financial companies here in New York, UBS, they were launching a specially designated Pride investment fund that was going to be traded as part of the stock exchange. And so they invited area ERG leaders to come in for a day to talk about ERG best practices. And for companies to be part of that fund, they had to score an 85% or more on HRC's Corporate Equality Index. And so we got to be there, and then we all got to show up on the trading floor for the closing bell, ring the bell, and there's rainbow flags everywhere. So that's an example of how ERGs, how LGBT employees can really help drive positive change, not just in healthcare, but in financial and other companies. So I think all those things are tips and ways that we can ensure that we're doing what we can to help our employers best meet the needs of their LGBTQ employees and help be better stewards of their community resources, et cetera.
Thank you, Greg. That's great. I love the chat as well. And thank you, Misty, for dropping that link. Lots of love for HRC. So I think, we've already started talking a bit about some of the tangible and practical solutions. I think Dr. Kaiser, I would love to hear some of the in overcoming medical biases. Can you speak a bit on that and some very practical kind of tips and best practices and guidance you would give to the medical community?
Absolutely. Important, concern is bias and how we're intentionally or unintentionally have personal or systemic kind of biases against patients or couples that are accessing healthcare. In preparation for the panel, I have to admit I'm embarrassed that it took me this long to get to it, but read How to Be an Anti-Racist by Ibram X. Kendi. And he talks in that book about the opposite of racism isn't not racism, it's being anti-racist. And so it really got, it struck a chord with me in terms of, we talk about LGBTQ kind of competent care, LGBTQ friendly care. And, in my mind, is that enough to be LGBTQ friendly? In the times that we're living in, is a more appropriate way to think about your practice being anti-homophobic in that same vein. And so I think it kind of gave me the language to think about, day-to-day operations of a fertility practice of ways that systemically, there might be some type of structural homophobia kind of baked into the clinical care and kind of the operations of an organization. And these aren't intentional, but they are kind of deep-seated and pervasive, and at first glance, probably overlooked by many people. But I think when you start to drill down into it, you can see these biases that are inherent to how we practice medicine, and some of it is as simple as and kind of patient-facing as website presence and kind of social media content in terms of, when LGBTQ posts are made, is it in June or in preparation for June only, or is it like kind of Pride 365 year round? Is there like LGBTQ content and like, medically accurate content on websites, and is it on the front page of websites? And then, just from the patient experience, from the initial phone call to filling out intake forms to the initial consultation, the actual kind of arc of treatment, where the potential snags that can be addressed. And, we've looked critically at how we collect data on patients and the folks that we're caring for in terms of, we historically have had, kind of quote unquote counted LGBTQ in terms of asking, sexual orientation and kind of gender identity and expression. Now over the years have incorporated that into all patient intake forms and ask about gender affirming hormonal treatment or surgical transition for all patients. Just, not assuming anything in terms of how someone's presenting. And, sometimes the medical record itself, the technology that we're using to document these encounters can be biased too. And, some templated notes, are gendered or assume like a heterosexual kind of orientation. So some of it's kind of decoupling that assumption that someone who wants to have a family is heterosexual and like has been actively trying for X amount of years. And allowing pronouns to be included in the intake forms and EMR, allowing nicknames or kind of chosen names to be included in the EMR, and there's some unique things in terms of how fertility charts are set up traditionally, and basically kind of the querying of the medical record of allowing these unique combinations of donors and gestational surrogates to medically accurately reflect the relationship that they're embarking upon. So it's a really nuanced issue, particularly in reproductive medicine, in that we're talking about egg and sperm and whoever has a uterus, but the genders are not always assumed, shouldn't always be assumed, and partner status should not always be assumed. So it's just making sure intake forms, folks that are answering phone calls and the medical record are all congruent and are inclusive, frankly.
Yeah, all great points. I think having worked in the healthcare system becomes particularly, even on clinical trials, right, challenging to change up very old systems and old forms and old ways of doing things. And I think it takes a lot of energy and allyship and coordination to really kind of press for that change. I think it's definitely an important point to articulate, some of those medical assumptions and biases that can happen there. I know we're getting close to time. I think I would love to close it out on sort of anything that we haven't covered on do's and don'ts, and whether it's as a manager, as a clinician, as a brand, as a thought leader, whatever it is. I would love to cover a few do's and don'ts. I think one particular one that I think it was you, Dr. Kaiser, highlighted was Pride is not just 1 month a year. So do Pride year round would be mine, but would love to open it up to you three. Lauren, maybe if you want to start and share some of your own do's and don'ts.
Yes, well, that sounds great. I would love to as well just chat about a couple of the resources that have been mentioned so that folks can get more information on do's and don'ts as well. But the HRC Foundation really focuses on improving equality for LGBTQ folks in every aspect of society. So where we live, work, learn, and heal. And wanted to just kind of touch really quickly on the Healthcare Equality Index as a thing and the Corporate Equality Index, since those have come up, and just talk a little bit about some do's and don'ts associated with those. So our Healthcare Equality Index is this great national benchmarking tool. It evaluates healthcare facilities policies and practices. We this year evaluated over 2,400 facilities nationwide. So it's an amazing tool to help do that. And we have an interactive map on the website that you can go to. And while you're there, you can click around in each state and see different facilities that have been evaluated and access really detailed information about what those services look like there. And just wanted to say, with regard to the importance of accessing that kind of culturally competent care that we've been talking about, as far as don'ts and missteps, the impact sometimes of going someplace that's not welcoming, as Dr. Kaiser mentioned, it can be a real chilling effect with regard to people accessing healthcare at all. So just wanted to talk about that as a really important potential outcome for that, for folks to keep in mind, that people's experiences in these kinds of vulnerable settings, that they really want to be treated with empathy, treated with compassion. Certainly, as I mentioned at the beginning, there's never an expectation that there would never be a mistake made for some reason, but really thinking about how important it is to maintain a welcoming facility to avoid deterring people from accessing care. And then also just wanted to give a quick shout to the Corporate Equality Index, which is something we've done for 20 years, score companies on a score up to 100 with regard to their inclusive policies, et cetera. This kind of data tells a story for employees and for others about what kind of company you are, and has been tremendously important for the past 2 decades for a number of LGBTQ employees trying to figure out where to work and where to frequent to purchase things. And just wanted to say, with regard to the point on what companies can do, really thinking about the experience of your employees. I've had several conversations with companies before that have talked about sort of like their hesitancy to gather data with regard to how many LGBTQ employees they have, that they were concerned about asking these kinds of questions, or concerned, I think, frankly, about opening themselves up to liability with regard to litigation if they were asking these kinds of questions or had this information on file. But just wanted to say that you can't move or improve something that you're not measuring. And it's really difficult as a company for you to gauge how you're doing with regard to inclusivity and belonging in the workplace if you're not taking the time to have some of those conversations, to talk to your workers, to see who may be willing to identify and talk through what that experience looks like for them.
Yeah, that's a really great point, Lauren. I think where I've seen it done really well is, having the ERG groups and things and supporting those and prioritizing those. I think, Greg, would love to hear from you around how that helps improve the employee experience and why that's so important, and some of the, you know, benefits you've seen, and maybe what some of the hurdles were, whether it was, you know, did you have issues gathering data, and did that come up at all? So I would love to hear your perspective on that and how you kind of worked through it.
Sure, thank you. I just put in the chat some organizations. I'm sorry I don't have specific links for those, but these are organizations that are doing a lot of great work and have best practices in research. So I would encourage people. GLMA has a partnership with Violet, where they are offering cultural competency training for providers, and they can get CME credits for those. So that's Fenway Institute out of Boston. They have a lot of great resources. They regularly have webinars on all aspects of LGBTQ health. So I would recommend that. One tip I wanted to sort of add into what Dr. Kaiser said is that you know, there are all kinds of fields that are available in many EMRs that patients in the privacy of their home in their patient portal can enter information that gets fed into those. So there's a whole series of fields that we call SOGI, sexual orientation, gender identity. And so they can put things in their preferred names. There's sections and fields where, particularly with gender reassignment, gender affirmation care, there's a list of organ inventory. So there's all kinds of ways. So providers and receptionists, medical practices can encourage patients to use the patient portal, particularly for those fields that are applicable to LGBTQ patients. I think that's a really good thing to do. So yeah, Kate, you know, one thing that we've done at Emblem Health with PRISM is we've started that we call a PRISM Healthcare Coalition, where we invite area social service organizations, FQHCs, other organizations that may specialize in all aspects of health for LGBTQ patients. And we convene quarterly, 90 minutes, where these folks come in and we have a loose agenda and they talk about issues, obstacles, things that they're doing, volunteer opportunities. We talked at one point about, you know, they were having issues with some of their patients, didn't realize that there were specific Medicare, Medicaid benefits that applied to them. And so we talked to them and talked about tips of how do you help navigate some of your patients through some of those hurdles. So those are things that do. And then we've talked about employee engagement. You know, that's one thing that organizations are talking about, left and right employee engagement. Well, one way to do that is to ensure that you're providing opportunities for your employees to be part of the ERGs, and not just sort of a token pat in the head. Oh, we're glad you're here. Yes, we'll help you fund a pride party. But how can you give us, you know, recommendations? What can we do better? Marketing, communications. The gay community has a huge history of really being innovative in marketing communication efforts. So tap into that. Tap into their networks to help you benefit your business, your organization. You know, work within what type of you know, initiatives and structure that you have, you know, to incent people. It may not be money. I mean, some companies do actually give an extra stipend to their ERG leaders. But how can you build some of the work that they do into the structures that you already have to reward and incentivize employees, and have them be part of your HR committees to talk about how can we build those structures. So those are some great tips. I know we're coming to the end, so I don't want to like continue talking until the very end. So thanks again. Hopefully those are helpful tools for people.
Yeah, no, all great points and topics. I'm sure we could continue on for another hour very easily. Dr. Kaiser, any quick last points you want to add in terms of do's and don'ts, particularly for, you know, the medical and political space?
Absolutely. So for do's and don'ts, you know, thinking about it on like a company level as an employer, on the doctor, individual kind of clinician level, and then separately on the patient level. In terms of the company level, would encourage, you know, CEOs and the decision makers in large organizations to critically think of and evaluate their fertility benefits packages and how inclusive their insurance plans that they're electing on behalf of their employees, what that looks like, on the fine print, and don't assume that that your employees don't care about this. Resolve, which is a national advocacy organization in kind of the fertility space, a couple years ago published some over 75% of employees rated like access to fertility care as either important or very important in finding and sticking with the same job. So whether your employees are talking about it or not, they really critically value this aspect of their medical care. On the doctor level, briefly, I would say critically assess how your own practice is either serving or failing to serve this population, and don't assume anything. Don't assume the sexual orientation or gender of a patient or their kind of intent or what services they're seeking out. Let them tell you what they're looking for. And then on a patient level, do speak up if your needs are not being met, and don't hesitate to look for a second opinion. There are physicians, there are clinics that do this really well. So just be sure to seek them out.
Thank you so much, and thank you to all three of you. I see, Lauren, you answered. It was a great question from Catherine about whether or not there are any indexes for insurance plans. It is a great idea. But thank you, all three of you, for joining. It's been wonderful having you all, and hope to do this again very soon. So thank you again, and thank you for all of our attendees who joined.
Thanks, Kate.
Thank you, Kate.
Thank you.